Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gollin.
Welcome to the Gastro Girl podcast. This is the first in a special 4-episode series sponsored by Castle Biosciences and brought to you in collaboration with expert clinicians and researchers dedicated to improving patient outcomes. Joining me for the first episode in this series is Dr. Lister, a leading foregut surgeon and president of the American Foregut Society. He is also founder of the Arkansas Heartburn Treatment Center, and he is here to help us understand the connection between GERD, Barrett's esophagus, and help us understand what we can do to protect our long-term health. Let's get started. Welcome, Dr. Lister. It's so great to have you on the show.
Oh, it's my pleasure. I'm excited to be here.
And you're kicking off the first of our amazing series, as we mentioned earlier, on Barrett's esophagus. And this is a really important episode because we're going to dive into all the basics. So to start with, what is GERD and how common is it?
So GERD, or gastroesophageal reflux disease, it's where acid comes up from the stomach into the esophagus. And its typical symptom is heartburn. But it can be manifested in a variety of ways that we'll get into later. But 1 in 5 people in the U.S. have GERD on a regular basis. So it's a huge problem. And the biggest thing that scares me is most people don't realize that it is the cause of esophageal cancer. So it's something you can't ignore. It's not just a nuisance. It's important to understand that it's a dangerous disease and you need to get checked.
Yeah, so most people, we just deal with it, right? We feel a little burning. We just take a couple Tums and move on with our day. And a lot of people will do this over and over again without really thinking about the risk factors, what they're doing to contribute to GERD. And also, like you just mentioned, why it's dangerous for it to go untreated and undetected for so long and even not, looked at and, with greater detail, because it could turn into something more, like you said, esophageal cancer. So what are the main risk factors for developing GERD?
So, there are lifestyle factors. So your diet, spicy foods, chocolate, peppermint, caffeine, alcohol, all work to relax the lower esophageal sphincter, which is the doorway between the stomach and the esophagus. Being overweight is a huge problem because that increases the pressure in the belly. And when you squeeze on the stomach, it has one of 2 ways to go, either downstream or upstream. And downstream is getting squeezed on at the same pressure as the stomach. So it wants to go upstream, and upstream is into the esophagus, causing reflux. People can have hiatal hernias. If you smoke, it not only makes you more likely to reflux, it also makes you more likely to get esophageal cancer. And things like stress will cause people to overproduce acid in their stomach so they can get a variety of symptoms, including reflux. And there's also health related causes. So if you are overweight, or let's say you've had a pregnancy, then you've had all of this increased pressure in the belly, which can lead to a hiatal hernia. Same way if you have a job that involves heavy lifting all the time, you really put a lot of pressure on that natural opening in the diaphragm, and you just stretch it open over time, like taking a styrofoam cup and sticking a pencil through the side of it and start turning the pencil. The hole just gets bigger and bigger. And that's what happens with the hiatus, or the opening in the diaphragm that the esophagus goes through over time. Certain medications, blood pressure medicines, asthma medicines, antidepressants, antihistamines can increase your risk of GERD. And also for women, hormonal changes, like we said, pregnancy, all of these can cause GERD. And we're seeing GERD more often in females as age increases. So used to be thought of as mainly a male disease, but we're seeing more females with it. We're also seeing more females with esophageal cancer. So it is something we have to pay attention to.
Well, first of all, I loved your description of the pencil in the styrofoam cup. That was so visual and it made me go, oh my goodness. It makes total sense. It's a really good visual to explain what's happening to the esophagus. And, many people, myself included, sometimes think reflux just means heartburn. Can you help us understand the broader range of GERD symptoms?
So, the two main typical symptoms of GERD are heartburn and regurgitation. So, either that burning sensation behind your breastbone where you're getting acid into the esophagus. The esophagus hates acid. It's not built to withstand acid. So, it gets burned. So, you get heartburn. Regurgitation is where you actually have food come all the way up into your mouth. But it can be more than that. It can be throat clearing, it can be hoarseness, uh, pain, or trouble swallowing. We see people lose their voice, singers that aren't able to sing as well uh, because they are getting acid up on their vocal cords. And instead of being able to sing for 3 hours in a concert, 30 minutes in, they're all of a sudden starting to lose their voice or cough or clear their throat. We see people with dental problems where they're losing the enamel on their teeth from the acid refluxing up into their mouth and just eating away at their enamel, especially if they have reflux at nighttime while they're asleep. Asthma like symptoms, chest pain, people think they're having a heart attack. So there's a wide variety of symptoms that people often don't think of as reflux, especially those atypical, sinus problems, just postnasal drip can all be caused by reflux.
Now, these symptoms don't have to be consistent. They can come and go. They can be a mixture of symptoms, right? And they can worsen with some foods that we may eat, right? Is that true?
Yes, yeah. Foods like we mentioned earlier, foods like chocolate, peppermints, all relax that lower esophageal sphincter. Acidic things like if you like a nice tomato sauce on your pasta, or if you like a lot of orange juice or tomato juice, things like that can increase your reflux symptoms. And the other thing that people really need to realize is um, if your symptoms go away, that is a huge red flag. So, people are like, oh, I've had to take over the counter medicines for years, and now I don't have to take it anymore, doc. My reflux went away. Well, unless you were on Ozempic or tirzepatide and lost 50 pounds, your reflux probably didn't get away. You just developed Barrett's esophagus. And once you
Mhm.
develop Barrett's esophagus, which is the first step down the road towards esophageal cancer, you typically no longer feel your reflux because you've replaced the esophageal lining with a lining that's more like stomach lining. So it doesn't mind the acid. It actually likes it and it's used to it. Unfortunately, that's the very first step down the road to cancer. I always describe to my patients a field: normal esophagus, reflux esophagitis, Barrett's esophagus, and then a fence. And then on the other side of the fence, you've got Barrett's with low grade dysplasia, Barrett's with high grade dysplasia, and then a cliff called esophageal cancer. As long as you're on the good side of the fence, you're okay. But the closer you are to the fence, the more danger you're in. And reflux is what pushes people towards the fence and ultimately towards that cliff. And the vast majority, probably only 20% of people or less, understand that that's a risk.
That has got to be the most profound and important statement that I've heard in a long time, and it's very eye-opening. I've never heard anyone describe it like that. Thank you, our patients, people who are listening. That's pretty amazing insight, and you said it in a very simple way, and it's a wow way.
Well, I'm a good old country boy. I live in Arkansas, and I like to describe things in ways that I understand it. If you start using big medical terminology, people's eyes just glaze over, and they don't get it. So I like to use things that I understand, and simple things that just make sense. Because the more the patient can get it and they have that aha moment of, oh, yeah, that's me, then they're more likely to follow your advice. They're more likely to get tested. So I thank you.
No, it
This,
was an aha moment.
opportunities like this,
It was a very
opportunities like this are so important.
it was a huge aha moment, uh, myself included. So thank you for that. Now, I know we're creeping towards the fence in our discussion. So if someone has GERD for a long time, how does that affect their overall health long term?
Well, not only is there the risk of getting Barrett's esophagus, which about 1 in 17 people in the U.S. will get. Um, and that's the only known precursor for esophageal adenocarcinoma, which is the fastest growing cancer in the U.S., up over 700% since 1970. It's also the second most deadly cancer, behind only pancreas, uh, where your 5 year survival, if you get esophageal cancer, is only about 20%. And we haven't really improved that in the last 30 years. So it's a disease you don't want to get. But not only that, there's other problems. Reflux can get into the lungs and cause pulmonary fibrosis. Uh, I've had patients that have had to undergo lung transplants because of their longstanding reflux. Um, it will cause asthma flare-ups. It will cause trouble swallowing. There's a wide variety of problems that are not just the nuisance of heartburn or the extreme of cancer. It can cause more problems with heart and lungs, and just your overall health, because it interferes with your sleep if you're refluxing at night. uh, if you have sleep apnea, that's going to make your reflux worse. So there's all sorts of things that interact with each other that make this disease worse over time.
The lung connection is very interesting to me, because I know some people who have had this chronic, this older woman that I'm friends with, chronic cough, constant, acid reflux, and I'm like, and she's had lung issues. So do doctors normally make that connection between the acid reflux and the pulmonary side?
Unfortunately, not all, like family practice or your internal medicine doctors, if they're not really tuned into foregut, they just kind of gloss over that, and they look for asthma, and they look for infections and all of these other things that cause cough, and usually until they get to an ENT, uh, that actually looks at their vocal cords and sees the inflammation and the swelling around the vocal cords, does that light bulb come on that says, "Oh, this could be reflux." But we'll get people get lung CTs, and they have this kind of honeycomb
Oh,
look, and especially in the bases of their lungs, and that's really telltale of pulmonary fibrosis, where the acid just gets down in there and then it just starts eating the inside of the lung.
oh wow.
And if you do have to have a lung transplant, most people will get a Nissen fundoplication, because the number one cause of rejection of your
Is
transplanted lung is reflux.
Wow.
So it really is important.
Well, thank you for explaining that a little bit more. I know you touched on what is Barrett's esophagus, but let's talk a little bit more. Let's lay the groundwork for what Barrett's esophagus is and who is at risk. What are some of the risk factors?
So, the main risk factors are longstanding GERD, historically male, Caucasian, over 50, overweight, history of smoking, and a family history of Barrett's esophagus or esophageal cancer, and the fact that you have a hiatal hernia, which just really leads to reflux. Any three of those puts you at risk. So you don't have to necessarily have the symptoms of heartburn, because you may have already passed that. You know, when you were in your 20s, you had heartburn and it went away. But if you're male, white, and over 50, you should get screened. If you're a female, but you're overweight and you smoke, you should get screened, because unfortunately, this disease doesn't show up until, or well, the disease of esophageal cancer doesn't show up until it's too late. The first time people come to see me is when they have trouble swallowing, and I do a scope on them and find an esophageal cancer
Oh.
at the junction of the esophagus and the stomach, and then it's too late. I mean, that patient has an 80% chance of being dead within 5 years, no matter what I do.
Oh.
And if we can educate people that if they've had these symptoms, just say, "Hey, doc, I need to get screened," and become proactive in your health and take control of that. And if the doctor you're seeing blows you off and doesn't want to get you screened, find somebody else that will, because it really can save your life.
And that's so important. I think, as patients, we need to advocate for ourselves. And if you feel something intuitively is wrong and you don't like the answer that you've been given by a doctor or a healthcare provider, it's so true. You find somebody else. Don't be afraid. You're in control of this.
Definitely. It's in this day and age where, doctors, especially primary care doctors, are graded on how many check boxes they have of did you screen for obesity? Did you screen for smoking?
Mhm.
Are their immunizations up to date? What was their blood sugar? All of these things, and that take that in conjunction with I've got to see 50 patients today. They don't have time to delve into asking the probing questions of, have you ever had reflux? So it's really important that the patient does that, because you're your best advocate. If you know, if the squeaky wheel gets the grease, if you are going, "Hey doc, I'm worried that I might be getting esophageal cancer, or that I might have Barrett's esophagus," they're going to get you checked, hopefully.
Yeah, and this is why this series, again, thank you to Castle Biosciences for really bringing this subject to light and bringing the importance of why we should be delving into this topic for patients. The more patients know, the more they can have educated conversations and feel confident in having those discussions with their providers. Not like they have to just accept what's told to them. They can challenge a little bit. And I would think if I was a provider, I would like to be challenged a little bit. I probably see many, many patients, and it's probably overwhelming at times. You kind of just answer the right things. But if someone's asking you questions, it makes you think a little more, maybe dive a little deeper. So it really is a shared decision-making process. So these series are so important. But let's get into our next question, which is, God, this is such a good one. Why is early detection of Barrett so critical?
Well, the sad thing about the disease of esophageal cancer is we know its precursor, and that's Barrett's esophagus. 90% of people who develop esophageal cancer have never been screened for Barrett's, and that's a huge number. The sad thing is we have incredibly effective treatments if if you're on the wrong side of that fence. If you have Barrett's with dysplasia, 98% of the time we can treat it and get rid of it without surgery, just by doing what's called endoscopic eradication therapy or radiofrequency ablation of that Barrett's, and we can get rid of it and never let you get to that cliff. And Castle Biosciences has developed an incredibly powerful test called TissueCypher, which lets us individualize the care of the patient. It allows me as the physician to look at 9 different DNA markers on each patient's Barrett cells, and it tells me what risk they are of progressing to high grade dysplasia or cancer in the next 5 years. So if you have non-dysplastic Barrett's and you're on the safe side of the fence, but you have a really high risk score, then that the alarm is going off. I'm going to pay really close attention to you, or maybe even go ahead and ablate you and get rid of that Barrett's before you ever jump the fence. And that's how we're going to save lives in this disease, is in a personalized approach for each individual patient, and controlling their reflux, not just masking the symptoms. And that's probably one of the biggest misconceptions that people have. When you take acid blocking medicines like PPIs, the Nexiums and the Prilosec and the Previcids of the world, you do not decrease your reflux at all. Zero. All you do is decrease the amount of acid in your stomach, so what's refluxing up doesn't burn as much. You still have the exact same amount of reflux. And the problem with that is while symptomatically you're better, non-acid reflux still damages the esophagus and still pushes you towards that fence and towards the cliff ultimately.
I just had a light bulb moment. I was thinking about colorectal cancer and colonoscopy and all the education and awareness. I've worked for ACG for 6 years, and this was a big mission, was to get screened. And if it was detected early, you could eliminate the cancer, right? To get those precancerous polyps out of the colon, and you wouldn't have colon cancer. I'm thinking like it's the same thing almost, only it's a different part of your body. And the amazing technology with this TissueCypher, not only you screen the patient for Barrett's, but you can also risk stratify them to understand which patients are more at risk, so you know what actions to take when. And I think this is a huge evolution in our understanding of something that we didn't really know about, which was Barrett's esophagus. It's not talked about like colon cancer is. I mean, granted, there still needs to be screening, and the screening, we still want everyone to get screened, but this part of your body, the esophagus, needs some love too, and it needs attention.
Well, and whenever you have a colonoscopy, if they see a polyp, it's removed.
Yep.
Unfortunately, we leave Barrett's behind. Regular Barrett's and adenomatous polyps of the colon, which are the precancerous types of colon polyps, have the exact same malignant potential. If you had left that colon polyp in the colon, it has the same potential, exact same percentage chance of turning into colon cancer as the non-dysplastic Barrett's has of turning into esophageal cancer. But nobody is going to leave a colon polyp behind. Unfortunately, in Barrett's and upper scopes, we leave that precancerous cells behind, and then we go, okay, hopefully when you come back in 3 to 5 years, you're still on the field. You haven't fallen off the cliff. Unfortunately, there's a large number of people who come back for that next endoscopy and they already have cancer. So, we can do a better job. And I think that's where the test of TissueCypher is really going to play a role in that because not everybody moves towards the fence at the same speed. There are some people that are just, crawling through the field, and there are some people who are sprinting through the field. And unfortunately, when you do a scope, you're taking a static picture. You're taking a still image of where they're at. You don't know how fast they're moving until you take the second picture, maybe 3 years later. And, you see how far they've traveled. With TissueCypher, it's kind of like that, the Apple Live picture. So you can actually see the little video, the little 3-second video of, oh, there's movement there. So you can see how fast they're moving, and you can go, oh, I need to pay attention to that patient. So it really is going to be a game changer, and it's an incredibly powerful tool. I encourage patients to ask their doctor, hey, are you using TissueCypher? Because it really is probably, other than radiofrequency ablation, it's probably the biggest game changer in Barrett's that I've ever seen in my career.
Yeah, and that's why we normally don't talk about products, but this is so important. It's such an evolution, like you said, in the ability to identify the risk and to remove the risk, right? When you're doing the TissueCypher.
Well, and if let's say you're 75 and you come back with a risk score of 0.5. The score is a score between 0 and 10. 10 being you're sprinting, you're moving as fast as you can towards the cliff. 0 is you're standing still. So if you're 75 and you come back with a score of 0.5, you don't need another scope because you're not going to get esophageal cancer in your lifetime. So it not only can shorten the interval on the people that we need to scope sooner, it also allows us to lengthen that interval so people aren't having to waste money on having a scope every year when they need one every 5 or 10. So it really allows us for that individualized care that everyone wants nowadays of, what's best for me, doctor, not what's best for the population as a whole, but what's best for me. And that's what we're striving to do in Barrett's.
Can we just clarify? I know we're going to get into this in this follow-up episodes, but when a patient is screened, when you do the endoscopy, when does the TissueCypher come in? And then what's the next step? You don't do the ablation, then they would come back and do that?
Right. So it doesn't change anything on the initial endoscopy.
Okay.
Biopsies are taken of the tissue that may be Barrett's or that looks like Barrett's because it has a very characteristic appearance when you're doing the scope. If those biopsies do come back with Barrett's esophagus, then TissueCypher is ordered.
Okay.
And that can be sent off. It can be sent off 1 or 2 years later. So if you had a scope a year ago and you're watching this podcast and you go, oh, I want that test, you can reach out to your gastroenterologist or whoever did your endoscopy and say, hey, can you order that? And they can send that off. They just send the slides that the pathologist made off, and then they get that score back. And then what's the game plan? Because then we know we either need to watch you very soon, we need to ablate you, or you're safe. We can extend your interval between 3 and 5 years, for example, as opposed to just sending everybody into the bucket of, okay, we're going to scope you again in 5 years, because some of those people are going to fall out of the bucket and either not return because they didn't understand how important Barrett's was, or they're going to get esophageal cancer. And either one of those can be a tragedy, because if they're lost to follow-up, they'll eventually follow up with when they can't swallow.
Well, thank you for that explanation. I think this is so important. It's such good information. And I love that patients are now have some information about, even if they've had the endoscopy, they can follow up with their doctor and ask for this TissueCypher.
The main thing is just don't ignore your symptoms. And if you've had reflux, even if it was in the past, 10 years ago, but you don't have it anymore, talk to your doctor. Look at your risk factors, and if screening makes sense for you, get screened.
Well, I'm so enlightened by this episode and everything that you've shared with us. And I really appreciate you breaking down such an important and often misunderstood topic. And listeners, if you've been living with reflux, I hope today's episode encourages you to take the next step, whether it's a conversation with your doctor or looking into your screening options. And be sure to join us for our next episode, where we'll talk about what happens during diagnosis and surveillance for Barrett's esophagus, including what to expect from an endoscopy, how biopsies work, and the role of advanced testing in guided care. Thank you to Castle Biosciences for sponsoring this special education series. And don't forget to like, share, and subscribe to the YouTube channel, and as well as on your favorite podcasting platform. Thank you very much. And thank you so much, Dr. Lister, for joining us today.
Thank you for the opportunity.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. please consult a licensed clinician in your state regarding all matters related to your health.